Welcome to the educational e-platform for training in neurological physiotherapy of the Faculty of Physiotherapy of the University of Valencia. In this video, we will talk about muscle rigidity in Parkinson's disease, and we will show a set of basic stretches to counteract this sign. One of the main motor signs of Parkinson's disease is muscle rigidity, which is defined as an increase in muscle tone, pathological, and is noticed by a resistance to movement, non-dependent on the speed or direction of this movement. Therefore, muscle rigidity is shown as a resistance to passive movement even during slow limb mobilization. This rigidity is produced by a simultaneous contraction of agonist and antagonist muscles due to deficits in reciprocal inhibition. Moreover, it is a sign that can cause pain in large muscles or joints, especially after long hours of immobilization, causing many patients to wake up with discomfort. Within the physiotherapy techniques to counteract muscle rigidity in Parkinson's disease, there is stretching, which should be part of the daily routine of a person with Parkinson's. So this video will show two basic sets of stretches, one assisted by the physiotherapist and another performed by the patient on its own. Stretching has not only been shown to have an immediate effect on muscle pain and rigidity, but also on the posture of the person with Parkinson's. Usually, people with Parkinson's disease are older adults who do not tolerate all postures, nor do they tolerate excessive changes in position, so the supine position will be chosen for assisted stretching. First, the stretching will begin in the head and neck, then in the upper limbs and then in the lower limbs. Each stretch should last a minimum of 20 to 30 seconds, and it will be performed during expiration or exhalation. We will start with a non-specific longitudinal neck stretch. We place our fingertips on each side of the spinous process of C2 so that the palm of our hands are placed on the external occipital protuberance. Our thumbs rest on the jawbone. We will pull gently towards ourselves. Next, we will add a head rotation to the previous stretching of the neck. With this, we will be stretching the neck muscles on the opposite side, such as the sternocleidomastoid and the head splenius muscle. We repeat the same on the other side. In the next stretching, we will lower the person's shoulder, keeping the head in a neutral position. This way we will be stretching the upper trapezius and the sternocleidomastoid. We repeat the same on the other side. To increase the intensity on the neck muscles, we will combine the rotation of the head with a shoulder descent on the opposite side. And we can perform this same maneuver and intensify the stretching by adding a flexion of the neck while the head is rotated. Remember to apply the maneuvers bilaterally. Another way to stretch the neck muscles is by placing our hand on the anterior part of the thorax. and, starting from the clavicle and the first ribs, apply a downward pressure to elongate the anterior neck muscles, sternocleidomastoid and scalene muscles. We repeat this stretching but combining it with a head rotation towards the opposite side from where the pressure is applied. We will combine the stretching with soft, non-painful muscle massage of the muscles. Next, in lateral decubitus position, we will mobilize the periscapular muscles. This will help counteract the flexor postural trend, which is characteristic of Parkinson's disease, and also to allow an active mobilization of the shoulder and shoulder girdle with less rigidity. The patient is placed close to the edge of the treatment table. The lower or distal hand of the physiotherapist will be placed under the patient's arm, holding the lower angle of the scapula. The other hand will be placed open on the patient's shoulder, leaving the thumb on the anterior surface of the joint and the rest of the fingers on the spine of the scapula. With these hand positions, we control the anteversion of the shoulder, since it is not unusual to find joint alterations or pain in the shoulder caused by the flexor postural trend in people with Parkinson's. Next, we match the patient's expiration with the passive mobilization of the scapula in different directions, focusing on scapular descent and adduction. Also rotations. To stretch the upper limb, we will take the person's hand, intertwining the fingers, and with the free hand we will stabilize the elbow. This way, while we stretch the arm, we are also able to manipulate the wrist and the opening of the hand more easily while the patient maintains supination. The stretching will begin from distal to proximal, always stretching the flexor muscles of the upper limb. In the video we can see how, while the extension of the metacarpophalangeal joints is facilitated, the wrist is extended and the elbow is left in extension. Additionally, we will ask the patient if he or she notices the tension, and if it's painful, they should inform us. Next, we add manipulation of the shoulder, bringing the arm outside the treatment table and downwards. We can repeat this in different degrees of shoulder abduction to stretch the pectoral muscles, as well as flexor muscles of the shoulder. For stretching the lower limb, we start again from distal to proximal, always stretching the most shortened muscles due to the Parkinsonian posture. At the beginning, we will focus on the dorsiflexion of the ankle to stretch the posterior muscles of the leg, which perform plantar flexion, leaving the knee completely extended. To add more tension, we will raise the leg so that the knee flexors and hip extensors are elongated. As we maintain the elevation, we can influence ankle dorsiflexion to increase muscle tension. Next, we will stretch the adductors and internal rotators of the hip, with the foot sole of the stretching side against the inner surface of the contralateral thigh. One of the physiotherapist's hand is positioned stabilizing the anterior superior iliac spine of the contralateral side, while the other hand pushes the flexed knee to facilitate its descent without causing pain and matching the expiration. To stretch the hip flexors, we will also stabilize with one of our hands the anterior superior iliac spine on the contralateral side of the stretching limb, and the leg to be stretched will be placed outside the treatment bed as seen in the video, and we will press the knee downwards with an extension of the anterior area of the hip. We will always ask the patient if he or she perceives tension. The gluteus muscles also generate muscle pain due to rigidity in people with Parkinson's disease, especially at the beginning of the day. To stretch them, we will bend the knee to the opposite side of the rotation while insisting on hip flexion. One of the physiotherapist's hands stabilizes the pelvis. Thank you for using this e-platform.
you.